It.
So welcome everybody to Hematology CCRN review, and we're very, very fortunate to have our wonderful colleague, Sarah Mitchell, and she's going to review hematology for you in this first hour of today's CCRN review. Take it away, Sarah.
Hello, everybody. Like Barbara said, my name is Sarah Mitchell. Previously, I worked at Grady as the surgical trauma ICU critical care educator, but I recently transitioned into a not hospital life and I'm now managing CRT programs with Baxter. So I'm going to review some hematology concepts that you may encounter on the CCRN exam, and we'll just kind of go over some different things that you might get into. All right. So just kind of to review what we're going to talk about a little bit today, we'll go over some hematology concepts, some immunology concepts, including some coagulopathies. Specifically, usually on the CCRN exam, they like to know about idiopathic thrombocytopenic purpura, DIC, HIT. We'll also review a couple of anticoagulation things, as well as some immune deficiencies, leukopenia. You guys can read all that good stuff. So just as a reminder, within your blood and kind of hematology, of course, talking about blood concepts, primarily your blood is made up of plasma, which is mostly water, also contains proteins like albumin. You have a portion of your electrolytes in there and some dissolved gases like oxygen, carbon dioxide. The other main part of your blood is comprised of erythrocytes, red blood cells, all that stuff carries oxygen. You'll know how that works. And then that last little percentage is buffy coat of platelets, leukocytes, your white blood cells, those sorts of things. So just as a reminder kind of that breakdown of your blood volume. Also, just kind of briefly looking back over the clotting cascade, you'll notice that you have two pathways where things can start. You have the contact activation or intrinsic pathway, which is going to be initiated whenever you have an endothelial injury or insult that occurs within the vessel. That's going to begin, with the damaged surface. Factor 12 is going to activate, which activates factor 11, and you have that pathway down ultimately until you have activation of factor 10. Conversely, or even concurrently, you can have activation of the extrinsic pathway, which is when tissue damage results in factor 3 or tissue factor, then activating factor 7, which works to activate factor 10 along with factor 5. It's a lot of factors, but basically, whether it's extrinsic or intrinsic, ultimately, when factor 10 is activated, that is then going to result in prothrombin being activated into thrombin, which activates fibrinogen into fibrin. Sorry, brain fart. Which is going to be able to allow you to have a cross-linked fibrin clot when everything works perfectly. There are a lot of places along the cascade where things can break down, especially because there are so many cofactors, proteins, vitamins that are required, electrolytes like calcium. You can see here calcium is critical in a couple of these different places. So you can see there are a lot of ways where if one thing is missing or one thing is consumed or inactivated or inhibited, that you will have an alteration in the clotting cascade. So as we're going along, we'll look at some conditions where you either have consumption of factors or inhibition of other factors due to loss of electrolytes or even vitamins, in addition to how medications are going to interact along this clotting cascade to affect coagulation. Just as a reminder, some different coagulation lab values that you will be, you may need to know the normals of, and you'll see different normals kind of depending on what reference text you're using. But as a generality, prothrombin time, you can see here the normal range. If that prothrombin time is elevated, of course, that means you have a prolonged bleed time. Prothrombin time is going to let us know about how the extrinsic pathway is functioning, the factors associated with that. And then it also is going to take into account that common pathway starting with factor 10 down to fibrin. Partial prothrombin time or activated partial prothrombin time, APTT or PTT, is going to give us some more information about the intrinsic pathway and all of those factors along there, how they're functioning, are if those factors are or loss of those factors are contributing to a prolonged bleed time. INR is going to go hand in hand with prothrombin time, and that's going to give us kind of a normalized ratio as the international normalized ratio. It's going to control for a couple of things within the patient, and it's also going to indicate if the patient has a prolonged bleed time. Fibrinogen is another common lab value that we'll look at whenever we are evaluating coagulation. Fibrinogen should exist in, essentially a certain number. And when we have a decreased number of fibrinogen evaluated in the blood sample, that can indicate that fibrinogen is being consumed. And when fibrinogen has been consumed, we cannot activate that into fibrin. So we will not have an ability to clot. And this commonly happens in DIC, or disseminated intravascular coagulopathy. Fibrin split products in kind of conjunction with fibrinogen, those are going to be in a higher amount whenever fibrinogen or fibrin-based clots are broken down, like happens in DIC. So fibrin split products or fibrin degradation products, you may hear that, those should exist in a very small concentration within the blood. And when those products are increased, it lets us know that we do have increased clot breakdown, again, like we see in DIC. Platelets, a very common coagulation lab value that we'll look at. When platelets are low, it's pretty non-specific. We have to gain a lot of other information to determine why are platelets low. Did we have loss of platelets due to a hemorrhage or consumption of platelets? And so we can figure out exactly what happened there. Similarly with D-dimer, it's pretty non-specific, but it is an indicator that there is some sort of clot formation within the body. So kind of just to review the coagulopathies we're going to look at particularly, we'll look at DIC, heparin-induced thrombocytopenia, and then idiopathic thrombocytopenic purpura. So with DIC, it's also known as a consumptive coagulopathy. With DIC, you have a primary issue that's happening. That primary issue essentially is causing an overwhelming insult to the system, which is going to result in initiation usually of the intrinsic pathway, whether that's from hypoxia, whether it's from an acidosis, or from the introduction of bacterial endotoxins into the patient's blood, like in sepsis. These sorts of situations can stimulate DIC in that they, again, injure the endothelial layer within the vessel wall, and that intrinsic pathway gets stimulated. The factors begin to be converted and activated, and those factors get consumed. In DIC, microclots form, and they may cause end organ damage as they clog up the capillaries and prevent oxygen and gas exchange from happening at the tissue level. DIC may be associated with petechial lesions, as those small microhemorrhages occur under the skin. A really significant form of that would be purpura fulminans, where you have kind of massive subcutaneous hemorrhage under the skin, and with that kind of microvascular congestion, the patient can actually have necrosis of large patches of their skin. DIC may progress to widespread hemorrhage, and it is associated with quite a high mortality rate. So recognizing DIC very, very early, catching it in that early phase, and then ultimately correcting the underlying issue is going to be really critical for rescuing these patients before they progress to a unrecoverable state. So with this graph, it's just kind of a pathway showing you how DIC can start, some of the things that happen within that, and how as those factors get consumed up, there's this vicious cycle of you have a stimulus which activates the clotting cascade. These clots then get broken down via fibrinolysis, and then you would keep trying to reinitiate that clotting cascade until those factors are completely consumed, resulting in widespread hemorrhage. And you can see some of the causes of DIC or massive trauma, sepsis, even cancer, products of conception, like you can see, and then direct injury of the endothelium as well. Give you a second just to kind of look over this or take a screenshot. Cool. So just to review some causes of DIC, kind of like I mentioned, that endothelial damage, which is going to stimulate that intrinsic pathway, those things including sepsis, hypoxia or acidosis, shock states, which, are classified usually by an acidosis, and can often have some level of tissue hypoxemia associated as well. ARDS, acute respiratory distress syndrome, AAA, and then of course cardiac arrest causes massive cellular insult, and can result in that overwhelming kind of stimulation of the clotting cascade. Additionally, release of tissue factor like the extrinsic pathway in extensive trauma, other types of malignancies, some OB emergencies like hemorrhage or, placental abruption, something like that, and then a dissecting aortic aneurysm. So you can imagine how conditions where you have hemorrhage already, your body is trying to keep up with that as much as it can, but ultimately, once those factors are consumed, if they are not replaced, or if you have consumption of some of the cofactors or the vitamins or things are inactivated that are necessary for clotting, some of those situations will not allow the body to be able to continue to create good effective clots, and you will have massive widespread hemorrhage. So the DIC lab values are things you kind of need to commit to memory. That's usually where the questions are going to head toward on the CCRN exam. Some hallmark lab values that we'll look at. You will have an increased PT and INR as well as a PTT. And that just talks about, how long it takes until you have clot formation. DIC is going to be, again, hallmarked by decreased fibrinogen because that fibrinogen has been consumed with those microclots as they're forming. You will have increased fibrin split products or those fibrin degradation products, letting you know that, yes, those microclots are also being broken down just about as soon as they're being formed. You may see decreased hematocrit in these patients, and you'll likely see an increased D-dimer. So treatment for DIC, kind of like I said earlier, treating the underlying cause is always the big thing. We may need to consider vitamin K administration in addition to replacing any blood components that may have been lost. If that patient has had consumption of clotting factors, we can replace a lot of those factors with FFP, fresh frozen plasma, with cryoprecipitate, or with even a prothrombin complex component complex or PCC. We can replace those clotting factors with these products, and so we can restore hopefully appropriate clotting if those factors have been consumed. We can consider administering platelets if the patient is having hemorrhage, of course, and then if they are actively hemorrhaging, we can replace RBCs or whole blood if the patient has an associated low hemoglobin or hematocrit with that hemorrhage. Back in the day, we considered using heparin to treat DIC because we knew we had this clotting, and so the clotting problem leading to consumption. And so the thought was to potentially use heparin to help control that undesired clotting, but it's not effective in acute or severe DIC, so not recommended for that. Moving on to heparin-induced thrombocytopenia, that is an immunologic reaction to heparin that activates platelet aggregation. Those activated platelets are going to cause thrombosis. We call that a white clot when it's platelet kind of only. This clot formation is going to lead to platelet consumption, which ultimately, similarly to clotting factor consumption, is going to lead to bleeding. These thromboses that occur when the platelets aggregate can cause CVA, an MI, PE, or really any sort of other vascular thrombosis or embolism. And often with HIT, the first sign is petechia. So the kind of classic lab that we're going to look for in a patient we're concerned that has HIT is a change in their platelet level. Patients who develop heparin-induced thrombocytopenia, again, are going to have thrombocytopenia, just meaning low platelets. And so you'll see a decrease in their actual platelet level. And we'll usually see that it's a 30 to 50% drop from their baseline, or if their platelets fall under 150,000, if that's different than their baseline. You won't see any major change in fibrinogen or an additional presence of those fibrin split products, unlike in DIC where you do see those things. It is quite mission critical that in a patient that we're initiating heparin therapy on, that we do have that baseline platelet count so we can evaluate for any change in platelets to ensure that the patient, if they have any bleeding or any changes in that we can recognize that early and get that taken care of. If we're concerned that a patient is developing or has developed heparin-induced thrombocytopenia, of course, the number one thing is to stop any heparin product going to the patient. Remembering, of course, that Lovenox is a heparin derivative. Usually your provider is going to order an assay to check for those heparin antibodies, which we can confirm that, yes, this is a heparin immune response. If that patient's requiring an anticoagulant, then we will just replace that with a non-heparin agent like bivalirudin, lepiridin, or gatroban. Those are IV agents, or we can consider dabigatran as an oral agent. We can also consider Coumadin or warfarin for patients who are able to tolerate that. And then we'll continue as that patient's recovering to assess their platelet count, and we may need to replace those platelets if the count is not recovering kind of on its own, or if the patient is having any active bleeding. If the patient's platelet count continues to fall and it falls below 50,000, we'll need to monitor really closely for any spontaneous bleeding to occur. The last kind of issue that we'll talk about that usually pops up is ITP, or idiopathic thrombocytopenic purpura. ITP is an autoimmune response that results in platelet consumption. Generally, the isolated lab abnormality is going to be a low platelet count. So you have a patient that they may be at home and they did notice that they have uncontrollable nosebleeds, or they bump into something and immediately have a huge bruise, or when they're brushing their teeth, their gums are just bleeding excessively. They go to the doctor, maybe they're fatigued, whatever's going on. They get a blood count and notice that their platelets are low. If the patient isn't having any of these symptoms, some patients are even asymptomatic, and often the symptoms are not like wildly concerning, and so patients may not get that kind of diagnosis early on. It rarely results in widespread hemorrhage. It's usually kind of these annoying things that you see, like the easy bruising, common, frequent nosebleeds, or that gum bleeding. To diagnose ITP, you kind of have to rule out everything else. So usually they'll do workups for all of the other common hematologic diseases and hemophilias, those sorts of things. ITP is not associated with any drug or systemic disease, unlike HIT, which is associated specifically with heparin. So you won't see, the immune response to heparin like you do with HIT, of course. So treatments for ITP, corticosteroids, considering immunoglobulins if that patient has severe bleeding. But in most adults, ITP is just kind of a chronic issue that they live with, and they'll get treatment, if they need it or if it's severe enough. All right, so just want to review a couple of medications that can affect coagulation. There are a lot of different ways that medications can affect coagulation. Like we talked about earlier, with there being so many steps in the coagulation cascade or in that process, there's a lot of places where things can go wrong. One of those ways that we can affect coagulation is by providing medications that have antiplatelet effects. You see here we have COX inhibitors, P2Y12 inhibitors, GP2A and 3B. These medications all affect the aggregation of platelets in some way or another. Platelets are outside of the clotting cascade. Platelets kind of bind together. The clotting cascade happens, which strengthens your clot and everything. So antiplatelet medications are going to work against platelet aggregation. Whereas you then have some medications that work directly in the clotting cascade, like direct thrombin inhibitors, which are going to inhibit thrombin from activating fibrinogen into fibrin. So when you have direct inhibition of thrombin, then you're not going to be able to create clots as effectively. And so those bleeding times generally are going to be prolonged. Other medications we have are indirect thrombin inhibitors. Sorry, just to back up, some of the direct thrombin inhibitors you can see listed here, like leparudin, bivalirudin, argatroban. Most of the direct thrombin inhibitors, I think, are IV medications. There are only a couple of oral ones that are direct thrombin inhibitors. So indirect thrombin inhibitors are usually going to function a little bit more on the activated 10 or activated factor 10 complex, where that is, required with factor 5 to then activate factor 2 or prothrombin. So indirect thrombin inhibitors like apixaban, like rivaroxaban, even low molecular weight heparin or Lovenox, and unfractionated heparin, those are all going to indirectly inhibit thrombin and affect the clotting cascade there. So warfarin or Coumadin is a little bit of a different medication in that its primary action is against vitamin K. And vitamin K is required as a cofactor in multiple points in the cascade to activate those, that kind of next factor in line. So when warfarin or Coumadin is working against vitamin K, you're not going to have that activation of the next factor. Which is why when we want to reverse Coumadin, we want to provide some brand new vitamin K usually. In addition to, we may need to administer new clotting factors to the patient so we can use those clotting factors and use that new vitamin K to enhance clotting and decrease bleeding times or coagulation times. Another type of medications that will affect coagulation, of course, thrombolytics. TPA is a very common one that we're all at least familiar with the name. And TPA is tissue plasminogen activator, and plasminogen is going to break down those fibrin clots. It's going to lyse those clots in order to break them up. And it's a lysing drug essentially that's going to slice through those clots that have been formed and allow that blood to flow more freely. So when we're looking at coagulopathies, determining the etiology of the coagulopathy is really going to drive management of that coagulopathy. If the coagulopathy is related to clotting factors that have been consumed or clotting factors that have been inhibited, replacing clotting factors and activators is usually going to be the goal. And a couple of ways that we can do that, we mentioned briefly. We can administer fresh frozen plasma, which is going to contain the necessary clotting factors, as well as fibrinogen and von Willebrand factor and other activators. And this comes, all these factors and, fibrinogen, the von Willebrand, they come in a lower concentration and a high volume. So especially in those patients who are, hemorrhaging or losing volume significantly, FFP is a really great choice to restore the clotting factors necessary in addition to that fibrinogen, as well as providing additional volume to the patient to restore any lost volume. In some situations where we have consumption of clotting factor, but we may not necessarily have large volume loss related to hemorrhage, then Kcentra or PCC, prothrombin complex concentrate, is a really great option in order to restore those clotting factors. In this case, they come inactivated and they come in a really small volume, so it's a high concentration. So we can administer those factors in a lower volume so that to avoid any volume overload for the patient and hopefully, manage their volume status a little bit better. If we're administering Kcentra or PCC, then we want to consider administering concurrent vitamin K, remembering that vitamin K is required for activation of a lot of clotting factors, several clotting factors in the cascade. And so if we have those clotting factors that are inactivated, without vitamin K and a couple of other things, we're not going to have those clotting factors to be activated anyway. Another thing we can consider administering is cryoprecipitate. It's course, a human-derived blood product that also contains the von Willebrand factor, several other factors, and fibrinogen. Unlike FFP, it is a slightly higher concentration and lower volume, so we may get a little bit more bang for our buck there if the patient doesn't need the additional volume resuscitation. Okay, kind of switching gears a little bit to talk a little bit about immune deficiencies, which you may see on your exam, and leukopenia, just kind of as a refresher if you haven't dealt with this too much. An immune deficiency results in some inability to defend against infectious sources. Leukopenia is just how we're going to refer to any decrease in white blood cells, and usually we'll call it leukopenia whenever the white blood cells are less than 4,000. A little bit more specifically, we do want to look at the patient's absolute neutrophil count, and when that ANC is less than 1,000, we'll consider that patient to be neutropenic. Neutropenic patients are at exceptionally high risk for infection. Immune deficiencies can have a lot of causes. Sometimes they're intentional, sometimes they are reactive to another situation that's going on and undesired. In the incidence of cancer, if we are leukemia, some sorts of things can really knock down the patient's immune system. And then, of course, when we administer chemotherapy, we're knocking out pretty much all of their cells. And so those patients often have leukopenia and even neutropenia related to chemotherapy. Of course, with immunosuppression, our goal is to knock down their normal immune response. And so you may see neutropenia and leukopenia in these patients as well. HIV infection, of course, that's going to make patients have immune problems also. And then even critical illness, patients often have an immune response in response to really any systemic insult. And so when they have that kind of initial response, eventually some of those mechanisms get depleted, similar to the coagulation problems. So like persistent, prolonged critical illnesses can create immune deficiencies as well. When a patient has neutropenia, we want to do our best, of course, to monitor for signs of infection, as well as preventing infections. In a patient who's neutropenic, so that ANC is less than 1,000, a neutropenic fever is considered to be a fever when you have just one temperature that's greater than 38.3 degrees Celsius. And, in most of our patients, we're like, it's one fever. We'll check on it a little bit later. In a neutropenic patient, that's really not an option because the organisms can proliferate so quickly and they can get very ill very fast. Another thing we have to do is make sure that we reduce contact for the patient with any potentially infectious organisms, even going so far as to limiting fresh fruit and vegetables, because those substances or those foods usually have some sort of infectious organisms on them if they're not washed really, really well. And even, exposure to a fairly benign infectious organism for one with no immune system, essentially, that can create a very significant illness. If patients are neutropenic, we're going to assess their white blood cells, we're going to assess their differential, and usually they'll get an absolute neutrophil count every day as well, especially as long as they're critically ill. We'll administer any ordered prophylactic anti-infectives if that's indicated, and then we will administer any ordered white blood cell production stimulants like Neupogen or Neulasta. And then, of course, as we're preventing infections, we're going to work to prevent sepsis because these neutropenic patients have no backup system. When their immune system is so low, they will develop overwhelming sepsis before we can even catch up. So really, really important that we are monitoring these patients super closely and recognizing any changes in their condition. Switching gears yet again, some oncologic complications that might pop up on your exam, particularly about pericardial effusions. This event may occur in up to 20% of patients with cancer, and makes sense that it's going to be mostly seen in those patients with some sort of chest cancer, like breast cancer or lung cancer, or even Hodgkin's lymphoma. With the pericardial effusion, they may develop that quickly or slowly. If they have a rapid progression of a pericardial effusion, of course, that's blood collecting around the heart within the pericardial sac. Rapid progression of that fluid or that blood is going to result in a cardiac tamponade. And, without intervention there, the patient will ultimately not be able to have a heartbeat. If we're concerned a patient has a pericardial effusion, then we will confirm that with echo, and they may decide to, depending on how significant or how severe it is, provide a treatment for that patient. So some treatment options for a malignant pericardial effusion: chemotherapy. We can kind of reduce that response with chemotherapy or with steroids if it is oncology related. Pericardiocentesis: if that patient's having a cardiac tamponade, they'll do that emergently and go ahead and remove off that fluid to allow the heart to fully expand, contract, fill, all those things. And then if the patient's having either recurrent pericardial effusions or they're concerned for a reaccumulation, they may opt to do a pericardial window and just pop in a drain so that they can allow that fluid to continually escape instead of reaccumulating. Okay, so lastly, we'll just talk quickly about transfusion reactions. With transfusion reactions, they can be acute or delayed. With acute reactions, they're generally going to show up in those first 5 to 15 minutes of a blood transfusion, which is why it's so critical that we are with the patient, kind of eyes on them for those first 15 minutes, so we can evaluate, is this patient going to have an acute reaction? If they are, it's going to show up during that time frame. They may develop acute respiratory changes. They may have dyspnea, any wheezing, stridor. Of course, if they're developing an anaphylactic reaction, they're going to have changes in their breathing ability as their airways swell and close up. They may have some cardiovascular changes like arrhythmias or tachycardia. They may have sudden jugular vein distension, especially if they're developing a circulatory collapse problem with the acute reaction. And then, of course, that may manifest as changes in blood pressure. It can be either hypertension or hypotension, depending on how things are going. The reactions are varied, and it just kind of depends on what's going on with the patient, just similar to a lot of other allergic reactions. You can, of course, have an immune response with a new fever. The patient may experience chills or rigors. They may have pruritus of their skin. They might develop a generalized rash or erythema to a particular area. And then if they're having a hemolytic reaction, they can have that petechia along their skin as well as everything's starting to break down. The patient may complain of some pain like a headache or chest pain. They may complain of kind of diffuse discomfort or abdominal pain, and they may complain of really significant back pain that's just all of a sudden and severe and very uncomfortable. Of course, if they have that hemolytic reaction, they may develop blood in their urine as well. If the patient has a transfusion reaction, step number 1, we want to stop the transfusion. You want to disconnect the blood tubing and go ahead and infuse normal saline through some new tubing. We'll continuously assess the patient, monitor vital signs closely, treat any symptoms that pop up, and then really important to check the blood for any discrepancies. So that would be for an acute reaction. We want to save the blood. There's usually a whole process for getting that back down to blood bank, making sure we recheck it against the patient's blood to determine what is the cause of this reaction. So it's more of the acute reactions. Some chronic reactions that I think I forgot to make a slide for are, so you can have transfusion related acute lung injury where the patient kind of has an immune response to that blood as well, and it ends up causing lung inflammation. You get an acute respiratory distress syndrome picture generally where the patient's having, worsened respiratory status, those sorts of things. The patient can develop transfusion-associated cardiac overload or with the administration of that additional volume, especially as we're giving multiple blood products, one after the other. If we're not kind of managing that volume appropriately, patients can develop the cardiac overload syndromes and, of course, develop respiratory failure related to that as well. Some massive transfusion complications that can occur. Massive transfusion is just defined as the transfusion of greater than 10 blood products within 24 hours. So you've probably seen at least one patient receive some sort of massive transfusion a very common problem with massive transfusion is that circulatory overload, because we're so focused usually on managing the blood pressure in the moment, or replacing FFP if the patient's consumptive in their clotting factors, those sorts of things, that we're just giving product after product, and that's interspersed with even IV fluids, that once we're done with the whole situation and we've kind of recovered the patient, that next day we realize, oh, they're very, very volume overloaded, and now we have problems ventilating. They can't breathe on their own, so they're trying to work against the vent, and we have to sedate them, and you just end up with a whole issue related to that volume overload. Additionally, we can develop electrolyte abnormalities with massive transfusion. A lot of times patients will develop hyperkalemia, as they may have lysis of some of those red blood cells. And then they often will usually develop hypocalcemia as well, as those blood products, specifically the red blood cells and FFP, are delivered into the patient, and they're all packed in sodium citrate. So the citrate is going to bind and chelate the calcium that's available in the patient's blood, and that calcium's not going to be available for use anymore. And so these patients will have acute hypocalcemia, and that is going to inhibit a lot of their coagulation as well, and that usually contributes to some coagulopathy. So with these massive transfusion patients, it's really important that, yes, we're administering blood products kind of in a balanced manner. We want to make sure that our red blood cells essentially equal the FFP, but that we're also administering calcium along with these transfusions to ensure that patients are not getting hypocalcemic. If they do develop that hypocalcemia, like I mentioned, you're probably going to have a persistent coagulopathy because we don't have enough calcium for activation along the clotting cascade. Hypothermia is a very, very common problem with massive transfusion, because even though we may deliver the blood through a warmer, through a massive transfuser, a rapid transfuser, the patient is still going to be exposed to some room temperature or even some cooled fluids. And so their temperature is usually very difficult to manage. So really important that we're monitoring their temperature continuously and having all of the warming measures essentially on for them, so that we keep them as warm as possible. Metabolic acidosis is a very common complication, and then coagulopathies, like I mentioned, as well. So I'll go over a couple of review questions and give you guys just some time to answer. In this first one, we have a 48-year-old male who was admitted with new onset shortness of breath and hypoxia, and he was diagnosed with bilateral PEs. High intensity therapeutic heparin is ordered for anticoagulation. Prior to heparin therapy, the patient's platelet count was 158,000. On day 2 of heparin therapy, the nurse noticed that the platelet count fell to 62,000. What is the nurse's next action? Let's read through the options. Option A, stop the heparin and notify the provider of the change in labs and the need for a HIT assay and alternate anticoagulant. Option B, nothing. The results are normal. C, bolus the patient with heparin and increase the drip. Or D, stop the heparin. Assuming you probably answered option A, that's the right one. You do want to, since we had that change in the platelet count that was pretty dramatic, it was definitely more than 30 to 50%. We want to stop that therapy, notify the provider immediately. They're likely going to go ahead and order that HIT assay and an alternate anticoagulant for the patient. Question number 2, an elderly patient was admitted 2 days ago with urosepsis. He is on vasopressors and he has diffuse oozing from IV catheter sites and his mucous membranes. The patient's current lab values are white blood cells of 17,000, platelet count of 43,000, his D-dimer is 5280, and his fibrinogen is 78. The critical care nurse knows to closely monitor for signs of which devastating complication? So options are acute distal tissue necrosis, acute hypoxemia and acidosis, acute respiratory failure, or lower GI bleed. So the patient, of course, is at risk for several things. With this, with his platelet count being so low, his fibrinogen is so low, I think this patient is most at risk for a new lower GI bleed, since he probably is in DIC. A middle-aged female is admitted status post-MVC with obvious bilateral lower extremity deformity. On arrival to the ER, the patient's BP is 80/40. She's immediately transfused with 2 units of O-neg PRBCs. The CT reveals a crushed pelvis and hemorrhage from right internal iliac artery. The patient is taken emergently to IR for embolization and receives an additional 6 units PRBC, 8 units FFP, 1 unit of platelet, and 2 grams of calcium chloride. The nurse knows to monitor for which electrolyte abnormality. So with all of that blood administration, she has received massive transfusion. We have replaced some calcium for her already, so I don't think shouldn't have hypocalcemia. But this patient is at risk for hyperkalemia as they're managing all these new cells in their body. They probably have definitely has some muscle tissue loss with the crushed pelvis and has had a significant hemorrhage already. The patient is receiving a blood transfusion for a hemoglobin of 6.2. Before transfusion, all vital signs were within normal limits. 5 minutes into the transfusion, the patient now complains of chest tightness, shivering, and has a temp of 38.4 degrees Celsius. The nurse assesses a heart rate of 133 on the monitor. What is the first action? Stop the blood. I'm sure you read through those already. Stop the blood immediately and infuse normal saline at Acavio with new tubing. And then you would, of course, go through the next actions of notifying your provider, and then do a workup for a blood transfusion reaction. A patient with leukemia is unresponsive to chemotherapy and is hospitalized for pneumonia. This patient's ANC is 475. Which intervention is most contraindicated? Ensuring the patient has fresh fruit with every meal, brushing the patient's teeth with a soft toothbrush, caring for the patient without neutropenic precautions, or retiming medications to promote adequate sleep. And yes, ensuring the patient has fresh fruit with every meal would be the most contraindicated thing because this patient is at very, very high risk for developing an infection. So we have to make sure that, all those sources of potential pathogens are mitigated. Barbara will be able to answer any questions. I'm so sorry I was not able to join you guys live. I have a different class I have to teach tomorrow in the morning, but I appreciate you guys for jumping on with me, and feel free to reach out if y'all need anything. Still here for you, even though I don't work at the Grady anymore, but it's all good. Thank you.
Thank you so much, Sarah. And my friends, we will be continuing on with acute crisis in endocrinology after a short intermission. Thank you so much. Bye-bye for now. Thank you again, Sarah. Bye-bye.